leverage and provide support to the human body. They are composed of calcium, phosphorus, and magnesium. Bones generally hold 99% of the body's calcium. Osteoporosis, or porous bone, is characterized by low bone mass and structural deterioration of bone tissue, which leads to bone fragility and increased susceptibility to fractures from the hip, spine, and wrist. Two essential cells are involved in the daily turnover of the bone: osteoblast cells and osteoclast cells. Overactivity of the osteoclast cells leads to osteoporosis. There are two types of osteoporosis: primary and secondary osteoporosis. Primary osteoporosis is in turn divided into type 1 and type 2. Symptoms of osteoporosis are swelling and joint pain, fracture, disfigurement, and debilitation, and kyphosis. Osteoporosis can be diagnosed by bone densitometry, ultrasound, and by quantitative computed tomography. Osteoporosis can be treated by changes in lifestyle, like quitting smoking, regular exercise, a balanced diet, and by taking medications such as estrogen replacement therapy, biphosphonates, alendronate and risedronate, or synthetic calcitonin or parathyroid hormone supplements.
The common bone disease in humans characterized by the low bone mass and the microarchitectural deterioration of the bone. It increases in bone fragility and susceptibility to fracture. Osteoporosis generally does not become clinically apparent until a fracture occurs. The usual osteoporotic fractures are commonly seen in vertebra, proximal femur, distal forearms. Patients suffer from pain, limited range of motion, disability, and deformity. Psychological symptoms like depression and loss of self-esteem. Fractures associated with increased risk of mortality and future fractures. A serious public health problem in India. 1 in 8 males or 1 in 3 females over age of 50 suffer from osteoporosis. Lower age of peak incidence by at least 10 to 20 years compared to Western countries. The pathophysiology, the bone remodeling necessary for maintaining bone strength. There is bone desorption and bone formation in normal individuals. In osteoporotic individuals, there is threefold increase of bone desorption and little of bone formation that causes acute bone loss. And if there is too much of resorption, too little of bone formation or no bone formation, can give rise to sustained bone loss. And aging, oestrogen deficiency in the other metabolic derangement, etc. The increased osteoclastic activity, decreased osteoblastic number activity, or combination of the two can give rise to bone desorption more than the bone formation, thus result in osteoporosis. The causes of osteoporosis. There are several factors like lifestyle factors like alcohol abuse, smoking, vitamin D deficiency, inadequate physical activity, low calcium intake, high salt intake, excessive thinness, excessive vitamin A, and immobilization. And other causes, genetic causes like osteogenesis imperfecta, Marfan syndrome, and hypogonadal disorders, GI disorders like celiac disease, gastric bypass cases. There are certain hematological disorders in hemophilia and thalassemia also, you will get osteoporosis. And rheumatological and autoimmune disorders like rheumatoid arthritis and ankylosing spondylosis, you will get osteoporosis. And other miscellaneous conditions and medical conditions which can cause drug abuse like anticoagulants, PPIs, and methotrexate can cause osteoporosis. And now the diagnosis. How will you diagnose a case of osteoporosis? The diagnosis is mainly by clinical symptomatology, physical examination, and according to WHO, some BMD assessments and imaging and other markers and bone markers. Physical examination may reveal occult fractures. For example, dorsal fractures, occult fractures. You can simply ask the patient to stand against a wall and you can find whether it is having a positive test or a negative test. The positive test says if the wall occiput distance is more than 0, that it shows there is some occult fracture in the dorsal spine. Similarly, if you want to test the lumbar spine, you have to see the rib pelvic distance by just palpating the lower border of the ribs and upper border of the pelvis. If the rib pelvic distance is less than 2 or equal, the 2 fingerprints, then we can say that there is some collapse in the lumbar vertebra. WHO defines osteoporosis in terms of BMD. The DEXA measurements of hip, spine, and established diagnosis of osteoporosis. As you all know, the normal bone density is less than -1, T-score less than -1, and low bone mass or osteopenia is -1 to -2.5. And it is more than -2.5, that is called as osteoporosis. Indications for BMD testing. Usually, regardless of the clinical risk factors, women aged more than 60, men aged more than 70, or with clinical risk factors for fractures like young postmenopausal women, women in menopausal transition, men aged in 5th and 6th decade, clinical risk factors for fracture, adults who have fracture after the age of 50, adults with conditions like rheumatoid arthritis, taking medications like glucocorticoids associated with low bone mass or bone loss. Bone mineral density, usually the sites measured are hip or spine. DEXA of the hip measurement at femoral neck, the red box, Watt's triangle, the blue box, the trochanter yellow region, and the intertrochanter region, the green region, and DEXA of lumbar spine measurement over L1 to L4 vertebra. It is little fallacious in cases of elderly patients who undergo this spine DEXA because of calcification of the aorta, and there are several artifacts. In case of degenerative diseases also, due to sclerosis also, you may have error in getting the DEXA results. In BMD testing, the importance of T-score and Z-score. What is T-score and Z-score? The T-score is the patient's T-score is BMD value compared with that of control subjects who are at their peak BMD. And the Z-scores are patient Z-score is BMD value compared with that of persons matched, age matched or sex matched or race matched. And other investigative modalities like vertebral imaging, vertebral fractures or vertebral imaging, the sign of impaired bone quality and strength, strong predictor of new vertebral and other fractures. Performed using lateral thoracic and lumbar spine X-rays, lateral vertebral fracture assessment. The presence of single vertebral fracture increases the risk of susceptibility to fractures of 5-fold. Risk of hip and other fractures increases 2 to 3-folds of susceptibility. The indications of vertebral imaging: women more than 70 years or men more than 80 years, or T-score at spine total equal neck score, femoral neck score is less than -1. All women aged between 65 to 70 and men 70 to 79 with T-score at spine total hip score at femoral neck -1.5. Post-menopausal women and men aged 50 and older with specific risk factors like low trauma fracture during adulthood, historical height loss more than 1.5 inches or more, prospective height loss more than 0.8 inches or more, recent or ongoing long-term glucocorticoid treatment. They also need vertebral imaging. There are certain biochemical markers of bone turnover. Bone remodeling occurs throughout life. Biochemical markers of bone remodeling include resorptive markers like CTX and NTX, formative markers like serum bone specific alkaline phosphatase and osteocalcin. Evaluating the biochemical markers of bone turnover predict risk of fracture, rapidity of bone loss, extent of fracture risk reduction, and the magnitude of BMD increases with the treatment. The FRAX, WHO Fracture Risk Assessment Tool, developed by WHO to evaluate the fracture risk of patients. The FRAX algorithm gives 10-year probability of fracture. These risk factors include, in WHO fracture risk assessment model is current age, older the age, more prone, and the risk for fractures. Gender, the feminine gender, females are more prone. Prior osteoporotic fractures, suppose a patient of elderly patient of giving history of recent fractures. Femoral neck BMD, BMD is low. Oral glucocorticoids use more than 3 months of duration in a patient of rheumatoid arthritis. Current smoking, alcoholic intake, 3 or more drinks per day. Parental history of hip fractures. Secondary causes of osteoporosis like type 1 diabetes, osteogenesis imperfecta, untreated long-standing hyperthyroidism, hypoparathyroidism, premature menopause. Additional bone densitometry technologies, CT-based absorptiometry, trabecular bone score, peripheral dual energy, X-ray absorptiometry, and the quantitative ultrasound densitometry. The management of osteoporosis. The management of osteoporosis is the general recommendations and the pharmacological therapy, and of course, for the surgeon, the surgical management of osteoporotic fragile fractures. General recommendation: adequate daily intake of calcium and vitamin D. The National Orthopedic Foundation recommended 1000 mg per day of calcium to men between 50 to 70, 1200 mg of calcium women aged more than 51 and men aged more than 71. The controlled clinical trials show reduced fracture risk with combination of supplemental calcium and vitamin D. The National Osteoporosis Foundation recommended the vitamin D levels intake of 800 to 1000 international units per day for adults aged 50 and over. Vitamin D deficient individuals, high dose followed by maintenance therapy. Usually we give 8 doses of vitamin D weekly basis, 60,000 units weekly for 8 doses, followed by monthly 60,000 for the lifetime in deficient patients. And always one should see the signs and symptoms of vitamin D toxicity. In vitamin D deficient individual, high dose followed by maintenance therapy is recommended. The general recommendations: regular weight bearing and muscle strengthening exercises. Exercises will play a very important role in the management of osteoporosis. There are different set of exercises for the adults as well as for the elderly people. For the young adults, we can do the muscle strengthening exercises. Muscle strengthening exercise against resistance or with weights is always better to make the bones stronger. And in elderly patients, aerobic exercises and other light exercises. And exercises to improve the reflexes, because in elderly patients, usually they do have some postural problems or some dizziness due to some drugs. And they should be regularly trained for exercises to improve the reflexes. Cessation of tobacco, avoidance of excessive alcohol intake is recommended just to prevent osteoporosis. Because smoking and alcohol, they also cause problem in causing the osteoporosis, because they cause lack of osteogenesis. They prevent osteogenesis and new bone formation. Postmenopausal women and men aged over 50 and older presenting with following to be considered: vertebral fracture, clinical or symptomatic or hip fracture, hip dorsal lumbar spine T-scores equal or minus 2.5, low bone mass T-score -1 to -2.2. 10-year probability of hip fractures more than 3% based on Frack's algorithm. 10-year probability of major osteoporosis related fracture more than 20% based on Frack's algorithm. And now the most important management of osteoporosis is anti-resorptive medications. We commonly use these drugs in day-to-day practice. One should be aware of the indications, the dosage, and the treatment duration of these drugs. In the anti-resorptive medications, mostly we use bisphosphonates like alendronate, ivandronate, risedronate, and zoledronic acid. But out of the 4 drugs, zoledronic acid is given in IV form once in a year for 3 years. This is a wonderful drug. I still practice giving this drug in management of elderly osteoporotic fractures, especially spine fractures. And the calcitonin, estrogens. Estrogen is also very, very important drug for the management of women with osteoporosis. Estrogen antagonist like relaxipin, tissue selective estrogen complex, and anabolic medications like parathyroid hormone, PTH, teriparatide, the synthetic parathormone we routinely use in some of the cases of osteoporosis. They got different indications that has to be given for a period of more than 2 to 3 years. The guidelines from American Association of Clinical Endocrinologists for choosing drugs to treat osteoporosis. First line agents like alendronate, risedronate, and zoledronic acid. Second line agent ivandronate. Ivandronate is a monthly given drug. Once in a month, in empty stomach we usually give, and that can be continued for up to 2 years. Second, third line agent like Rajashrkhar, that is also good drug for patients who are having some cancer, breast cancer, or whatever, that will help in giving relief to those patients. Last line agent is calcitonin. Calcitonin we usually use in vertebral spine fractures due to osteoporosis. Patients with very high fracture risk whom bisphosphonate therapy fails, then we use teriparatide. The newer agents like denosumab, fully human monoclonal antibody agent, RANKL, inhibits osteoclast-mediated bone desorption, reduced incidence of fracture after 3 years of use. And the evidence-based clinical efficacy of medications. This is the interesting chart. One can go through this chart that indicates anti-resorptive drugs, the efficacy on spine and hip and non-vertebral regions, like wrist and other bone fractures. Bisphosphonates like alendronate, ritonate, and abandronate are quite good for spine and hip and non-vertebral fractures. Abandronate is only good for spine fractures. Zoledronic acid, it acts all the 3 fractures. Denosumab, again 3 sites. And teriparatide is for spine and non-vertebral fractures. And the other side, the route of administration is given. Now the individualizing the osteoporosis therapy. Clinical scenario is like primary prevention treatment of post-menopausal osteoporosis. What is the drug to be given? The drug is alendronate, ritonate, zoledronic acid, denosumab. Patient with osteoporosis, chronic kidney disease, again denosumab. In kidney disease, we cannot give other drugs. Patients with osteoporosis with high risk of hip fractures, again, as I said, alendronate, ritonate, zoledronic acid, and denosumab. Patients with multiple vertebral compression fracture, consider teriparatide, bisphosphonates, Rajashrkhar, denosumab in the order. Patients with osteoporosis will have prior history of esophageal anomalies, gastric bypass surgery, GI intolerance. These patients to be given by IV zoledronic acid, denosumab, and teriparatide. Patient at high risk of glucocorticoid-induced osteoporosis, alendronate, ritonate, zoledronic acid, consider teriparatide also. Recently, postmenopausal women with low BMD in spine is at high risk for breast cancer. Rajashrkhar reduces the vertebral fragility fracture incidence and reduces the risk of invasive breast cancer. Older postmenopausal women who have taken Rajashrkhar for several years, BMD is stable, no incident fractures on treatment, consider switching to first-line agent for postmenopausal osteoporosis like alendronate, ritonate, and zoledronic acid. Other newer agents like strontium renylate, long-term registered trials after 5 years demonstrated gain in BMD, bone quality, improved reduction in risk of vertebral and non-vertebral fractures. The conclusion: currently, number of medications available of osteoporosis. Each drug possesses specific advantages and side effects. Like bisphosphonates have been mainstay of osteoporosis therapy, but questions exist about very long-term safety. Bisphosphonates needs to be taken on an empty stomach, staying upright, and delaying food for 1 hour. Teriparatide be given as daily subcutaneous injection and used for a definite period of time. Relaxation increases menopausal heart flashes and risk for DVT and embolism. There is need for drugs that could, with high safety, increase bone mass, improve biomechanics, reduces fracture risk, more than two existing products while giving long-term, long-lasting benefits even if treatment is stopped. New and potentially highly effective agents may offer novel therapeutic tools to counteract osteoporotic epidemic. Request Mr. Amit to show the video. And before concluding, I want to show some of the surgical managements of osteoporotic fractures.
Most people above the age of 60 to 65 years suffer from back pain. Osteoporosis frequently causes vertebral compression that further results the vertebral body to collapse, resulting into a fracture. Patients suffering from this lose bone mass over time. As a result, the spine becomes weak and is no longer able to take the body weight. Hence, patients start developing severe back pain and a progressive loss of height is noticed. Kyphoplasty and vertebroplasty are the most effective, minimally invasive, pain-relieving treatments for the elderly patients. Kyphoplasty is a procedure in which the compression fracture of the spine is rectified. Typically, a special instrument with a deflated balloon is inserted into the fractured vertebra and is carefully inflated to create a cavity within the fracture. Once the space is created, the balloon is gently removed. Bone cement is then injected into the void space that hardens quickly, thus stabilizing, strengthening, and helping to reshape the vertebra. Vertebroplasty is a minimally invasive surgical procedure. In this, two hollow needles are put through the pedicles into the fractured vertebral body. Through special delivery mechanism, bone cement is injected. The bone cement quickly hardens, thus stabilizing the fracture, offering structural support to the vertebra. Both kyphoplasty and vertebroplasty relieve pain and give stability to the spine. These procedures help stabilize vertebral compression fractures and angle of the affected vertebrae, thus restoring it to a more normal height and shape. Most people above the age of 60 to 65